So now I'm going to move on with the second speaker today. So we have Professor Ross Baker. Thank you, Professor, to be here today. So we are going to talk about making integration work for complex patients. So Professor Baker is professor at the Institute of Health Policy Management and Evaluation at the University of Toronto and program lead in quality improvement and patient safety. Professor Baker is co-lead for a large quality improvement training program in Ontario, IDEAS, for improving and driving excellence across sectors. Professor Baker is also a co-principal investigator of the Canadian Adverse Event Study and chair of a WHO working group on patient safety measurement and method. Among his recent research projects, he had led a review and synthesis of evidence on factors linked to high-performing healthcare systems, an analysis of why progress on patient safety has been slower than expected, and an edited book of case studies on patient engagement strategies. Thank you, Professor Baker, to be here today.
So thank you very much. It's a real pleasure to be in Montreal and to be here with a group of people who really bring a lot of expertise from different perspectives on this topic, and I look forward to conversation. I'm going to change gears a little bit and focus. Systems are very important, and we all have a view about how to create systems, but I think it starts to come into different focus when you pick out particular populations that have key system needs. And I'm going to focus on complex patients and the way in which we build systems, some of the evidence we have around the key success factors for those systems, and then what that means in terms of changing the current ways in which we're delivering care. And I come from Ontario, so I'm going to talk mostly about Ontario and use some evidence and examples from elsewhere. So I think everybody starts with this sort of wake-up call that we are living in a world where the status quo no longer serves us well, and where we don't really have a choice. It's adapt or face system failure, I think. And we could add other factors to this, but clearly part of what's going on is an epidemiological demographic challenge. And I'll say a little bit more about that. In the context of changing technology, changing delivery factors, the continuation of resistance to change that stems from a variety of issues, including continuing concerns about professional autonomy at the point of care and limited integration across the system. So this is the world we live in, and in politically driven, publicly funded systems, we all know that there are few resources, and in fact, healthcare is now driving out much of the investment that goes into other sectors. And so it's a challenge as we take a big picture view about how do we create more effective healthcare in this environment. The good news, or maybe it's not good news, is that we're all in the same boat together. And whether you're in England or in Europe or in the United States or in Canada, all these systems face these challenges. They have somewhat different responses to that. Helen Bevan, who has for a couple of decades really been at the front end of change in the UK, had this nice quote, the end of which says, there is a need for big picture transformational changes that can be translated into practical changes that deliver quality and productivity benefits for every patient and for the whole country, talking about England. So we can learn a lot from what happens in different political and social contexts, and we all face the same challenges moving forward. So as I said, I'm going to talk about Ontario and Ontario's transformation journey, and just to say, I think that there's this challenge about creating a political and policy agenda that addresses those big system issues that I outlined. And then there's the even larger challenge of translating that policy agenda into changes at the front line. And I think my view on this, to summarize, is that Ontario's had a pretty good track record at identifying what the challenges are and a pretty good understanding of what some of the system changes have to be, and is still working on this critical third piece of then how do we translate that into things that are going to make a difference for patients and populations in the province. So the current strategy of the government is to focus on changing the investments in different sectors, moving more resources into primary care, community-based care, and to create greater understanding of how we focus on the integration of those sectors, both structurally and in terms of linking providers together at the point of care. And one of the prominent initiatives in this is called Healthlinks. Healthlinks are the voluntary efforts to bring together people from acute care, community-based care, other care sectors, including long-term care, and then non-healthcare providers, including in some cases the police and other people working in community with complex patients, those patients who are multimorbid, who have continuing interactions with the healthcare system, and who have proven to be one of the most difficult challenges for our current system because we're not integrated to the point that we need to be to deliver care. And this initiative now is 4 years old and has been rolled out across the province. There are currently 78 health links in different geographies. The goal is to have roughly 96 of these serving complex patients across the province. This is the most recent data on Healthlinks and the core activities around these groups of physicians and other providers who've come together to talk about individual patients is to create coordinated care plans for these patients that link the services in the community, in the hospital, and elsewhere to provide ongoing support for these patients to improve their care, improve their health, and reduce the cost of care for the government. Now, the good news is you can see the two graphs here are not only increasing, but the slope of them seems to be increasing gradually over time. The challenge is that we have 30,000 coordinated care plans created in the province of Ontario, which has a population of 14 million. And the data estimates are that there are probably 600,000 of these people across the province. So yes, we're moving in the right direction, but we're moving at a pace now that is not going to have the impact that it needs to have moving forward. Access to primary care, also a critical issue to ensure that these patients who are some of the most challenging patients in primary care are now attached on an ongoing basis to physicians or nurse practitioners to provide them with a continuing source of care and coordination for their healthcare needs. And again, you see this sort of nice slope upwards, but not at a rate that's going to have I think a significant impact on this population. The agenda in Ontario is called the Patients First Act, and this is the structural agenda that brings together primary care in a more deliberate fashion and home and community care. And given the sort of legacy of the creation of Medicare in this country, we are still sort of tiptoeing around this issue about how integrated physicians are going to be in these structures. This is an issue that our colleagues from the US may find a little confusing, but we still see this as two parts of the equation. We talk about the organization of medical care, and then we talk about the structures in which physicians and other care providers work as if they're two separate efforts rather than one that has to have a coherency and integration. Home care is coordinated in Ontario through these bodies called Community Care Access Centers. And the big change now, which is about to roll out across the province, is the integration of these CCACs into the 14 regional bodies that deliver and oversee the resources that come from the Ministry of Health on a geographic basis across the province. So CCACs, which had been independent agencies coordinating care in the home for patients who come out of hospital, are now being integrated into these organizations called LINs, Local Health Integration Networks. Now, on the surface, it seems like a good idea. Why not put these pieces together? The challenge is that the LINs are fairly small bodies. They're really coordinating mostly at a policy level with some limited oversight. The CCACs are larger bodies, and in any system change like this, any massive change, what you discover is that there's a huge fallout in terms of the continuity of managerial resources and leadership in these agencies as they move. So of the 14 CCACs, 13 of the chief executive officers have decided that they don't want to be part of this new structure. In many cases, some of the other members of these senior management teams have also left for other opportunities. And so in Toronto, for example, of the 6 or 7 senior leaders in the CCAC, only one is going into the structure, and she has indicated that that's a short-term sort of continuity game. So creating new structures may have some long-term benefit, but it has short-term costs. And I was in Alberta last week listening to a talk by the chief medical officer talking about the Alberta healthcare system. And Alberta went from a regional structure to a single integrated structure across the province in 2008. And they are still struggling with how to work effectively within that system. So I don't argue that structure isn't important. I think structure is important, but my personal view is we need to think about integration as something that happens across settings, across organizations, as well as within some larger structures. And it's really the focus of what happens at the front line. Integration is measured by the ability of frontline providers to share information and make decisions in the best interest of the patients that they see, period. Right? That's the total value of integration. It's not around whether or not we have one flag to put over everybody who works in the system. So you hear my bias on this, but I think there's some evidence to suggest that we often delay rather than accelerate improvement if we focus on structure alone. So I've said a little bit of this already, but why did Ontario walk into this journey? I borrowed this slide from Helen Angus, former Associate Deputy Minister in the Ministry of Health and Long-Term Care in Ontario. And she has this nice little $24 billion bullseye in the middle of that demographic surge that we see coming in Ontario. So if we don't do anything to change the way in which we deliver care in Ontario, the costs will go up $24 billion in the next period in order to continue to meet these needs in the current fashion. We can't afford that. We can't afford anything close to that without totally undermining the stability and the integrity of the healthcare system. And so we need to change. And the other reality, and this is not coming across very well, but is this changing patterns of multimorbidity in Ontario, in Canada, in fact, in the Western world. So you see this is just a, the slide doesn't show this very clearly, but this is the change between 2003 and 2009. And these are various segments of the population in terms of the number of conditions. And so the largest number of conditions, large number of people have one condition, and you can sort of see the division between this little slices of this and this. So the top level is a slice of the population that has 5 or more chronic conditions moving forward. And you can see for people who are 65 or older, almost everybody has at least one chronic condition. And a growing number have 2, 3, 4, 5 or more chronic conditions. So this creates a challenge for the system where we have developed evidence based on individual chronic conditions, not based on multimorbidity, and where the impact of multiple conditions changes the dynamic in the system and the complexity of the care that needs to be provided. And it also changes the cost structure. So this is the reality that we live in now, that in Ontario, for the small 3.5% of the population that has 5 or more chronic conditions, we spend a quarter of our healthcare resources. And if you look at the population that has 2 or more conditions, which is a large percentage of people over 65, we're spending almost 3/4 of our total system spending. And of course, this can be looked at in a variety of different ways. And this is the graph that has grabbed a whole lot of attention in the system. Comes from work that my colleague Walter Wutchis has done, looking at the administrative data on costs for everybody receiving care in Ontario. And it says, and the same pattern is true in the US, across Canada, and in other developed systems, that 1% of the patients are using essentially 1/3 of the resources in the system. 5% of patients in the system are using 2/3 of these resources. And you can see the average expenditure for people in that top 1% is $40,000 a year, now approaching $45,000 or more a year. So there's an old joke about a bank robber named Willie Sutton, who creates or carries out a number of robberies and is finally caught and brought to justice. And he's convicted of his crimes. But before he's sentenced, the judge pauses and he says, well, Willie, can you tell me why you rob banks? And he looks very confused and he looks around. He says, well, Judge, that's where the money is. So here's the issue, right? I mean, this is a very appealing slide because it says to policymakers and people who are running the delivery system, the senior leaders, if you really want to focus on costs, and by the way, focus on improving care for a significant slice of the population, you should focus on this 1% to 5% because that's where the money is. And that's where the care needs are too, as we'll see in a moment. There is a challenge to that. And the challenge is, first of all, that this 1% to 5% is not a homogeneous population. It's made up of several important subgroups, one of which is this multimorbid complex population that I showed in the earlier slide. But there are people who move in and out of this group who have very expensive episodes and then no longer need care. And 16% of this group within a 3-year span dies, right? So it suggests, first of all, that not everybody needs to be treated in the same way within this group. We need to identify and target certain sub-segments of this group. And secondly, it suggests, and this is the bigger challenge in my view, is that being in the 1% to 5%, it may be too late to have effective interventions that are going to change the trajectory of your health status and your care, right? So we need to move upstream to ask who are going to be the people in the 1% to 5% in 3 years or 5 years or 10 years. Right? And that raises this, I think, important issue about how do we integrate population health in a more meaningful way in our system so that we can move upstream, so we can influence those determinants that are going to change the outcomes for this population. So the big question is, how do you create a system of care to focus on these complex patients, because they're driving a large part of the expenditures, and their ability to maintain or recover their health is a critical issue in terms of the performance of the system as a whole. So we need to create a system of interdependent elements working together to achieve a common goal. We have the interdependent elements. What I would suggest to you is that we don't always have a common goal. So I'm working on a project now with Jean-Louis Denis and Mylène Breton and others in Quebec, and then a team headed by Tim Keneally and Tony Ashton in New Zealand, where we're doing case studies of organizations doing integrated care in 3 different settings, in Ontario, in Quebec, and in New Zealand. And we're trying to understand, these are organizations that are seen as relatively high performing, We're trying to understand their issues in terms of their development as organizations, in terms of the mechanisms that characterize the work that they do, the successes that they have in working with patients in the community, and in terms of what we need to understand in order to replicate, scale up, and spread, which, as Jean-Louis has said, is one of the critical issues facing us in a system. So we have a few high-performing organizations, but we need a system that's built on the principles that allows many organizations to do the same thing. So as we have worked through detailed set of interviews and data gathering across these cases, 3 cases in each of the different settings, we're coming to understand some of the issues that relate to the development of these different organizations, and there's some commonality to it. So in Ontario, because we have multiple models of integrated care, we focused on a traditional community health center, which has been around for 30 years or more. We're focusing on a community-based organization that started with the provision of Meals on Wheels to a senior Chinese population, which has now expanded into, with a family health team and a variety of other services, into trying to integrate care in that community. And then we're looking at a family health team located in a downtown Toronto hospital that works both in a clinic and in the hospital itself, organizing and integrating medical care, and now has been working with home care and other services in the community to wrap other services around that as well. And so some of the critical sort of factors related to developing this system-wide care coordination across those different environments in Ontario have to do with these things identified in the blue bubbles around relationships and trust, the knowledge that you can actually depend on others to provide this care. How do you develop those relationships? What's the assurance process when people change, when those relationships change? And a lot of that relating to communication and information sharing, role clarity in terms of who's doing what, who's responsible for what. The challenge of integration is that integration builds on a series of initiatives that sometimes have created structures that made sense at the time, but which now don't make much sense. And so when you create a new program, you're often creating resources to ensure that that program works effectively. But these integration efforts include multiple programs with multiple coordinators across a variety of different services. And now we have a hodgepodge of coordinators responsible for similar patients, instead of figuring out how to simplify that from a policy perspective, from a financing perspective, and most importantly, from a care delivery perspective. Leadership has been very important in the development of these initiatives, all these initiatives, partly because 30 years ago, developing integrated care in the community was not seen as a high priority compared to funding high-tech acute care services in our hospitals. And now the game has changed, but for these organizations to be in this game now, they've had to have the strong senior leadership, and they've had to develop leadership throughout the organization in order to carry this out. And leadership along with strategic direction, vision, and understanding of what they're trying to achieve. And then their ability to recruit people to work in environments where the pay is often less than it is in the acute care sector, but the rewards are different, right? The commitment is different. And so I think that's been an important part of moving forward on this. So that's the sort of a story we're trying to get. And then we're trying to understand what holds these organizations back and what will be the challenges as we scale up and spread these in different environments. And the challenges are represented in some of the icons across the top. The information coordination issue, whether it's digital or non-electronic, the time pressures on people who are facing increasing workloads on the front line and need to think about how they work more effectively, more efficiently, and the continuing system integration issues, this thing that's represented by the lightning bolt across the two sort of icons for different healthcare organizations. We talk about integration as if it's a simple matter of creating a set of policies for referral and follow-up, but it is much more complex than that as we get into it. So I don't think this is unique to Canada. This Ontario challenge, even in systems where you have these kinds of resources available within a single regional structure, you still have these continuing pressures that people feel there are different priorities depending on where you work, different ways of thinking about what the needs of a patient or client are, and different ways of communicating information that's critical in terms of deciding on next steps for care. So clarifying that, understanding that, I think is really a priority before we can make some decisions about how we're going to design larger systems. Now, as I say, these problems are shared by people everywhere. And this is a quote from Jared Anderson from Hopkins School of Public Health in the US. And he says what I've just said: governments, health plans, clinicians will soon be developing the next generation of programs designed to treat high need, high cost individuals. The reasons are clear. Everybody agrees that this should be a focus. They are the most costly. They often have the worst clinical outcomes. The problem is most of the interventions that have been attempted have not yet been able to achieve one or more of the triple aims: improving health, reducing costs, and improving the patient or client experience. And many of those that have been reported in the peer review literature as being successful are not operational a few years later, right? So this is not a problem we face alone, and I look forward to hearing more from our US colleagues about their stories moving forward. Now, on the other side of the coin, David Blumenfeld, the president of the Commonwealth Fund in the US, wrote a piece in JAMA in the fall, suggesting that, in fact, we are developing enough evidence that we can understand what are the critical issues moving forward, what are the things we have to do to create successful integrated care initiatives for high cost, high need patients. And you can see here a sort of theme about, again, understanding what structures, what processes, what communication issues are necessary to do that. How do we create a policy environment where we reward people for looking after these patients instead of penalizing them? So how do we create payment mechanisms and how do we create access for these patients, many of whom are not highly motivated to seek care, right? So they're avoiding care over long periods of time, and their health problems are becoming more complex as they do so. So, and the last point I think is the critical point, is that we need to encourage and we need to wrap around resources to understand what the experience is of different models in different settings. And, you know, I tip my hat to Don Berwick, who in his short time in the US government created an enormous resource for developing demonstration projects and evaluating those demonstration projects as a information source for people who are developing new integrated care services, not only for complex patients, but more generally. So what's the step forward on this in our system, and I think in any system? I think there's three key elements here, and they fit together very nicely. You need all three of them. It's not like choosing which one you really like to do and, you know, leaving the others aside. There's a continuing need to think more thoughtfully about the integration of services at different levels, at organizational levels and at frontline levels. And then as we do that, we have to ask this question: how do we move upstream, as I said before, to develop the services and the focus that allow us to intervene in people whose trajectory will make them the 1% patients in 5 years or 10 years? How do we do that without spending a whole lot of money on people who are not going in that direction? That question is, I think, a really challenging question. And then in doing this, we're going to change significantly the work of many people in the system. And my view is that those people need some support in doing this. It's not enough to say to send a memo to somebody telling them about how their work is about to change. We need to get in with resources, support, and an ear to hear what's necessary to change this. And I'll say a little bit more about one of the ways to do that. So this diagram reflects comments that Roxanne had earlier about the different levels of integration. But I think the important thing here is thinking about the fact that these things have to move together, right? It's not enough to create organizational integration, and then to say to the clinicians, you figure this out, you work out what has to happen. And it needs to also balance the population-based issues. What are the segments of the population we want to focus on, including this multimorbid segment, but not only that one, and the person-focused care. The view of the clinician in the room is that the patient who sits in front of her or him is the most important thing. And that's critical to successful care. But at the same time, we have to ask the question, what does that patient have in common with other parts of the population? How do we design care, as I said, to not only deal with the immediate clinical medical need that somebody has, but about the broader needs that they have at the present and may have in the future. So some factors in the literature, it's a growing literature now. One of the reviews I read said that they had looked at 1,000 articles dealing with successful integrated care. And so this is my take on it. It's not a highly methodological, rigorous scoping review. It's just my read of the issues in the literature. It starts with leadership, because without that leadership at a clinical level and a system level, then very little happens that makes a difference to patients. The stationery may change and the logos may change and things like this, but we have to ask what the real sort of value added is. And that, of course, means strong interprofessional teams, and broader than that, teams that include other providers in healthcare settings and in the community who are not professionals. The great majority of home care delivered in Ontario is delivered by personal support workers who have very little training, right? And they're in there doing a variety of important, critical tasks that without them wouldn't happen. Focus on community services as well as healthcare. So moving beyond outside of healthcare, which is a huge challenge in Ontario, and maybe less of a challenge in Quebec because of your history of thinking about the broader linkage between health and non-health services. Obviously, navigation, care coordination, organizing, ensuring the delivery of service on a regular basis. We have continuing issues in Ontario about people who come out of hospital-based care, cancer treatment, and then who don't get reliable home care services. And so they either scramble to get family members or they go without, and that's not high quality care. Linkages between primary and specialty care, hospital-based physicians and community-based physicians, information technology, which is siloed as much as the services are siloed, and effective organizational models, which are both patient and population focused. And then the second issue, and this is very closely tied, and so I have to say, I think that effective integrated care, by definition, for complex patients has to be population health sensitive. It has to include the broader issues in the community. If you want population health strategies, your first sort of issue is about segmentation, because we cannot afford to add a lot of services to the population as a whole. It won't be value added in the long run, although some people might like those services. So we have to figure out who are the individuals, the subgroups that are most likely to benefit moving forward. Predicting that is sometimes quite difficult because we're always looking retrospectively from the data. How do we embed care coordinators in integrated health teams? So part of the move of the CCACs into the LHINs will be a move of care coordinators out of the home care settings where they're now organizing care and into primary care and other settings in the community. And some of that has already gone on, but I had a conversation recently with somebody working in that area, and I said, so how's that working out? And she said, well, it's not so bad with our organized home care. So family health teams, interprofessional, multi-physician teams are a significant portion now of primary care in Ontario, probably serving a third of the population. But the rest of it is other models, including a continuing number of solo practice physicians. And she said, well, it's not so hard getting the family health teams. We know who they are. In fact, we're already there, right? We've been there for some period of time. She says, but figuring out who the other people are in any geography is a challenge. She says, the most useful thing we've done in Toronto is to have our care coordinators walk around the area that they're going to be coordinating carers and find the physicians in that area, right? And you're sitting there thinking, what does that say about the data systems, right? On all sides, on the primary care side, on the home care side, right? At the government level, that the best way to locate people is to walk around the neighborhood. So I'm not going to say any more about that, but clearly an issue. Addressing social as well as healthcare needs, investing in social services. So it's interesting in the UK, and I agree with Jean-Louis. I mean, England had this amazing trajectory in the Blair government, moving from a valiant but not high-performing health service into something that really was among the best national systems in the developed world. And it's been systematically undermined by cuts to healthcare, but even more drastic have been the cuts to social care in the UK, which is funded locally, which really undermines all their efforts to create integrated care. You say you want to create integrated care, and then you slash the resources available at the local community. It doesn't jive. It doesn't make sense to me. So we need to invest. We need to ensure that those people are going to be available to provide the services necessary on an individual level, as well as the population-based services they provide on an ongoing basis. Addressing population health determinants, I've already said. Creating better data about patient and service use to help coordinate, to help create strategy for what are the best ways to identify and provide care to those individuals. And then continuing engagement and involvement with patients and family. And there's a large literature that suggests that the most effective integrated care programs are the ones that have regular contact with their patients, not at a distance entirely, although that can be useful to supplement, but face-to-face contact. And it kind of sends shivers down people's spine because they realize the cost and the effort involved to do that. But there's as I say, there's a number of programs now which are evaluated. The most successful programs are the ones that see their patients once a month. And maybe it's the nurse practitioner or visiting nurse who does that, but who's in contact to get the information. Because we have to recognize that the most complex patients who are very difficult to reach are the ones that are the least likely to tell us about the things going wrong, because they have limited motivation to report it or limited sense that anyone is interested in their health. So continuing engagement with patients and family, supporting carers. One of the most effective things that the Ontario government has done recently is to create funding for respite care for carers, because we face this huge problem of caregiver burnout. You know, we rely on the unpaid work of caregivers to ensure that the system works, but now we have to look and say, how do we maintain that? How do we support that moving forward to make a difference? And then the continuing evolution as we learn more about the design of effective programs across Canada, in the US and elsewhere, I think is really critical moving forward. And then the third piece of this is this piece about change management, is supporting people, particularly at the front line, who have worked often for a period of time with an established manner of practice in the way they interact with their patients, how they see the patients, how they recruit those patients. And quite impressed with some recent work that one of my colleagues has done trying to pull together the literature on practice facilitation. I suggest people look at it. This is this little graphic is front cover of a handbook put together by AHRQ, the Agency for Healthcare Research and Quality in the US, which is a handbook for practice facilitators. Practice facilitators are people who work mostly in primary care in the US, in patient-centered medical homes, and other environments. They help physicians and other practitioners and the teams together develop the skills they need to adapt to the specific circumstances of their practice environment, which means working in different ways, coordinating care with different people, creating different methods of organizing the resources and delivering their care to ensure the continued health of these complex patients. And this, just to sort of bring this home, This is a list of the competencies for practice facilitation. And it starts out with, I think, this critical and underestimated skill of interpersonal skill and emotional intelligence to work with people who've sometimes worked in the same way for 10 or 15 years. And in the fall, a group of us did a site visit to Vermont, which is doing really interesting work in this area, trying to connect primary care to their other environments more explicitly, and then building a system which has essentially a one-payer model in an environment which isn't really politically always very favorable towards one-payer models. So it's creating this understanding of what practice facilitators can do. And in Vermont, we saw this in primary care, where we had a dialogue between the practice facilitator and a primary care physician who talked about how she helped him see how he could change his practice in a way that would serve his patients better, right? So great sort of example. Using simple tools, quality improvement and other things, and understanding the nature of the practice. So these people come out of primary care, practice facilitators, and understand that environment and people that they're working with. So that's the front line. That's what has to happen in the intersection of these frontline clinical environments. It's a huge evolution. We shouldn't underestimate the changes that have to occur in people currently practicing and people coming into that environment. But secondly, we have to recognize that in order for that to happen, there's a series of resources that have to be put into the system as a whole to create the leadership and vision about what this is going to look like, to create the interoperative electronic health record and the other technologies. So one of the most, I think, impressive achievements of the CCAC in Toronto recently was the development of a palliative care team that included people from the hospital and from home care, doctors and nurses and others, to allow patients to live and die at home by meeting on a regular basis, a morning huddle, to talk about the medical and the non-medical needs of these patients, their pain control, their medications moving forward. It sounds simple when I say it that way, but believe me, coordinating the schedules and the interaction between those people was anything but simple, right, to make it happen. Jodine Goldar and a team at the Toronto CCAC made that happen. And now it's a predictable way to help people receive palliative care in the community at their home. So integrated, coordinated teams, flexible funding models that recognize the challenge of these patients, that recognize the additional costs to develop and organize some of these integrated care programs, and then ongoing evaluation, which I've said before, is really critical to understanding what works and helping to spread it. And these comments that I've made are not unique to me alone. There's a wonderful resource that Claire Alcott and colleagues at the Health Foundation put together in the UK, that 7 critical success factors in the NHS. And it's around creating this environment that supports change. It's around a culture, committed and respected leadership, engaging staff, data, management practices that ensure execution, and things of that nature. It's the capability and the support at the front line which translates into better integration, not the diagram on the paper. So my conclusions, we face this tsunami of complex patients who will either bankrupt us or lead us to substantially shift the way in which we fund our healthcare system in ways that I don't think any of us in this country really want to see. We need to deal with their care. We need to do it in a way that's cost effective, and we need to do it in a way that gives them a better experience, because right now, for many people, it's not a good experience. This means new models of care, and it means I don't think we have the answers to what models work, and there will be different models in different environments. It will look different in rural areas than it does in urban areas. It will look different in small cities than it does in rural areas. So let's think about what this looks like. And the key on this is to focus on the clinical changes that have to happen and the relationships between staff at the front line in order to put these new systems into place. Thank you.
name is Multimorbidity. I'm the Associate Executive Director for Wakeup in Montreal. You mentioned that you're going through a process of integration with the CCAC with the rest of the system in Ontario, right? Now, this sounds to me exactly what we have been doing 10 years ago with the state project in Quebec.
Yes.
With the Systemness. In my experience, this has been a flop because from a lot of isolated institutions, we have created a synergy of integration, which is very positive. But what I see now, we have created in North America a system where acute care hospitals have all the money, the expertise, and the pride of the health system. And now we're telling them we want to change the triangle, reverse it. From what I have observed when I've visited the Scandinavian countries and some of us Israel and other places, you mentioned the UK, they have forced the system to transfer large amounts of money and expertise into the first line system and shrink the hospital system, acute care, into the third or fourth line where they belong as the expert of very specialized services. And in some places, the budgets are even outside of these hospitals, and they are like being asked to give a service by the community institution. Do you think there's any chance that this model be successful, as it seems to be in the Scandinavian countries, because they have increased their first-line services manyfold in the last years, and they seem to be very successful in keeping the services in the community, taking them out of the acute care hospitals. But in Canada, I think that it's going to be quite a challenge, if not a war. And I don't know that people will do it spontaneously, because this is not the culture. The culture is that expertise, money is in the acute care hospital. And if you may very well talk about trajectory, this is what we're trying to do,
Sure.
but to reverse the aha between past and what we want to go in the future, which is what you've shown us, doesn't seem to me like it's going to happen easily. I don't know what to say.
So it's a very complex issue, and you're right. I mean, the historic balance of resources and influence in the system has been in the acute care environment, really across the board. And so the question is, what are the strategies for balancing that in a way that will serve the population? There's a number of challenges to this. One of them is the political challenge, the small p politics of hospital leaders who have dominated healthcare dialogue in many settings for a long period of time. There's the larger P politics of politicians who don't want to face the headlines about cuts to hospital services and longer surgical waiting lists, et cetera, which is a very useful tactic for driving home the importance of hospital services. But there's a balancing to that, I would say, as well, because I think in many environments, hospitals have realized that their future lies in creating a system that balances the acute care services in their environments with the community-based services, and to think about this from a population perspective. So the work that's going on in the US right now in accountable care organizations and accountable communities has really suggested that hospitals will thrive in communities where there is this coalition and working together, sometimes under one organizational banner, but often cutting across different organizations. The complexity in the US is that you have competing systems in the same environment, right, who are all trying to develop these community linkages. And so how do you have population focus where You have to make a decision whether you belong to hospital A or hospital B in terms of the insurance plan, et cetera, et cetera. But I'm actually quite optimistic that people will start to see a common goal in creating systems that balance off acute care and long-term care. And you know, for more than a decade, probably 2 decades now, people have said that the future for hospitals is in highly specialized care. They will be, in a sense, intensive care units and surgical suites and emergency departments. And if people embrace that and then move to the question, so how do we do that in a way that ensures that our patients get good care across that system, which is a big concern, right? Because for many people, it's been the lack of resources in the community and the lack of understanding of who those people are and what care they're providing. Remember, in medicine, it's the personal relationships between clinicians that build trust to refer patients in a different direction. And so we have to build that understanding, that connection across the system in order to do that. And if we move too fast to create that integration, that sometimes we lose the opportunity to develop that kind of trust and rapport. So as I say, I'm an optimist because I think it's the only solution moving forward is we have to figure out how we integrate the work, the critical work that happens in the acute care environment with these other services that increasingly patients require in the community or elsewhere. And some of them may be provided by hospital-based clinicians, some of them not. And so there's really 2 models. One model is a sort of what sometimes referred to as a hospital hub, where the hospital manages the care for a cohort of patients, slice of the patients, and then there's a community-based hub. The reality is in many settings, and I can't speak to Quebec, but in many settings, the managerial expertise sits in the hospital. It doesn't sit in the community. And this was certainly the case in England as they moved to primary care trusts, commissioning care, and now clinical commissioning groups. Most of the people who are delivering clinical care in the community want to deliver care. They're not interested in the contracting and assurance processes necessary to make that happen. So we have to either build that capability into the community sector, or we have to rely on the hospitals to provide it. My view. It's not popular to say that in some parts of the community, I have to say.
Thank you very much for an excellent presentation. I think I finally understood what I think I'm an infectious disease doctor, and over the last 35 years, a lot of what you presented is actually what happened with HIV. Which went from diagnosis, not wanting to be diagnosed, death, potentially becoming chronic illness, with an integration that sort of evolved naturally by itself without any government input, but a lot of patient input. The part also that I find interesting is that this integration takes in the late 80s, early to late 80s, and especially hasn't been transferred to cancer care, hasn't been transferred to cardiac care, yet it was a superb model success.
Yeah.
And I'm almost wondering why can it not be transferred? What's the block?
Yeah, that's a very helpful insight. And you know, I'd be interested in your sense of this, but my sense of what happened in HIV/AIDS care is that it was a group of champions, really young champions who took risks with their career and risks with their own health because they saw the need in this population. And so they were working, they were borrowing and working around rules and regulations in the system in order to do these things that you say. And it was only when it showed that it had an impact that people said, oh, that seems like a good idea to coordinate the care that we're doing in ongoing management of these patients in the hospital, but recognizing that they're spending most of their time in the community and they have to rely on those resources, right?
My impression is that the difference because cancer is massively willingness and at the same time physician
that
actually immediately agree makes sense. The best example has to do with the management structure.
Yeah.
The addition of the open segment. So to me, everything that you presented happened in 1838, but the difference with cancer is really the fact that perishing body.
Yeah.
And it became the difference.
Yeah. Yeah.
And a lot, that's I think.
Thank you. Okay.